Okay. Hello, everyone. My name is Lachey Tate, and my group will present on reactive attachment disorder. And I will begin covering the overview of the diagnostics. Next slide, please. Next slide, please. So here are the basics. We will go further into depth along the way. So reactive attachment disorder occurs when the child experiences unmet emotional needs and or unmet physical needs and or many changes in caregivers, and it reacts with confused attachment to caregiver and or stranger danger. But child does not have a developmental delay such as mental retardation or persuasive developmental disorder. Next slide, please. So, what is reactive attachment disorder? Reactive attachment disorder, also known as RAD, is a complex, severe, and relatively uncommon condition in which infants and young children do not establish lasting healthy bonds with parents or caregivers. So while this condition is rare, it is serious. In most cases, a child with RAD has been the victim of abuse, neglect, or abandonment, or is orphaned. Reactive attachment disorder is known. Reactive attachment disorder is a condition in which an infant or young child does not form a secure, healthy emotional bond with his or her primary caregiver or parental figure. Children with RAD often have trouble managing their emotions, so they struggle to form meaningful connections with other people. Children with RAD rarely seek or show signs of comfort and may seem almost fearful of their caregivers, even in situations where the current parent figures seem quite loving and caring. So these children are often irritable or sad and may report feeling unsafe and or alone. Children children bond children bonds with children bond with adults who provide them with consistent and loving care. They recognize the adults who protect them and calm them when they are feeling stressed. So like in most cases, they develop healthy, secure attachments to their primary caregivers, like their parents, daycare providers, or perhaps a grandparent who is very involved. When children and babies struggle to form healthy relationships with a stable adult, they may develop reactive attachment disorder. This can have profound effects on child development and future bonds. Next slide, please. Reactive attachment disorder is a relatively new disorder. It was first introduced in the DSM in 1980. Reactive attachment disorder first made its appearance in standard psychological disorder in DSM-3. The disorder was eventually divided into two subcategories, which are inhibited and disinhibited. And this took place in 1987. That's when the two subtypes of reactive attachment disorder was introduced. Children expressing inhibited symptoms of RAD are extremely withdrawn and emotionally detached. While they are aware of their surroundings, they do not respond. Disinhibited behaviors with strangers that are overly friendly, talkative, or physical and or not age appropriate or culturally accepted. So in 2013, the diagnosis was updated again. The DSM-5 refers to the disinhibited type as a separate condition, which is now called disinhibited social engagement disorder. Disinhibited social engagement disorder is an attachment disorder that is also caused by a lack of secure attachment with a caregiver. Like reactive attachment disorder, children with disinhibited social engagement disorder approach and interact with unfamiliar adults without fear. They often are willing to go off with a stranger without hesitation, similar to the pictures I have here. Next slide, please. So, who is likely to have reactive attachment disorder? Reactive attachment disorder is most common among children between 9 months and 5 years old who have experienced physical or emotional neglect or abuse. While not as common in older children, not as common, older children can also have RAD, since RAD sometimes can be misdiagnosed as other behavioral emotional difficulties. Children may be more likely to develop RAD if they have many different foster care providers or spend time in orphanages, were taken away from primary caretakers after forming a healthy bond, have had multiple traumatic losses early in life. Next slide, please. So what causes reactive disorder? Although there is no exact cause, researchers believe that lack of appropriate level of loving and consistent caretaking contributes to development of RAD. Inadequate caregiving can make a child feel abandoned, alone, and uncared for, all of which can prevent that child from developing a healthy and secure emotional bond from his or her primary caretakers. Young children form healthy bonds, healthy relationships when their basic needs are met consistently attended to. This builds a sense of trust between the young child and caregiver. Some examples of inappropriate ongoing caregiver situations that place a child at risk of developing RAD include a baby whose diaper is soiled and not changed for hours, a baby who is hungry and not fed for many hours, a baby who is crying and not attended to, who is not comforted when they are in distress, a baby who is not held, touched, talked to, or interacted with for many hours at a time, an infant whose needs are met only some of the time, which meaning the caregiver is not consistent, a young child who only gains the attention of caregivers by acting up or being disruptive, a baby or young child who has had multiple caregivers, or any situation in which the child has been physically or emotionally neglected or abused by primary caretakers or other adults. So that wraps up the overview. We will now move on to the next person. Thank you.
Yes, my name is Susan Moore, and I will be talking about diagnostic criteria A. A consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers manifested by both of the following. The child rarely or minimally seeks comfort when they are distressed. The child rarely or minimally responds to comfort when distressed. The diagnostic criteria A explains that the child becomes uncomfortable towards an adult when in emotional situations, both in seeking comfort and responding to comfort in rare or minimal basis. Next slide. Thank you. Diagnostic criteria B. Although only one factor needs to be present, at least two symptoms must be present, which can be seen on the slide. If only one is present, reactive attachment disorder is not present. The symptoms must be a persistent social and emotional disturbance characterized by at least two of the following: minimal social and emotional responsiveness to others, limited positive affect, episodes of unexplained irritability, sadness, or fearfulness evident during even non-threatening interactions with adult caregivers. This diagnostic criteria explains that disturbances in social or emotional situations must have two symptoms in combination. These symptoms are either minimal, social or emotional responses to others, few positive moods, or episodes of being irritated, sad, or afraid, even during non-threatening situations with an adult. Next slide, please. Diagnostic criteria C. Although only one factor needs to be present out of the criteria stated in the slide, it must be in combination with criteria B. Child has experienced a pattern of extremes of insufficient care as evidenced by at least one of the following: social neglect or deprivation in the form of persistent lack of basic emotional needs for comfort, stimulation, and affection met by caregiving adults, repeated changes of primary caregivers that limit opportunities to form stable and secure attachments, rearing in unusual settings that severely limit opportunities to form selective attachments. Only one of these factors need to be present. The first criteria on this slide is how social neglect or a lack of basic emotional needs are met by an adult. The second on this slide shows that a change in caregivers happening repeatedly limits the chance to form attachments that are long-lasting. The final point on this slide under this criteria is about unusual settings, such as daycares where child to caregiver ratios are high, which limit chances for selective attachments. Next slide, please. Diagnostic criteria B. The care in criteria C is presumed to be responsible for disturbed behavior in criteria A. This criteria notes time frames between criteria C and criteria A. Criteria C, social neglect or deprivation, repeated changes in caregivers, or rearing in unusual settings must come before criteria A. Becoming uncomfortable in situations towards adults and in situations where comfort is offered on a minimal basis. Criteria D notes the time frame between criteria C and criteria A. Criteria C is supposedly first and exhibits the consequences of criteria A. So thus, as this slide depicts, we have the cause and the multiple effects that can stem from this cause. Next slide, please. Thank you. Diagnostic criteria E and F. Though other diagnoses can occur, you can only have reactive attachment disorder or autism spectrum disorder. Both cannot be present in the same individual. This disturbed behavior must occur before age 5. Criteria E, the criteria are not met before autism spectrum disorder. Autism spectrum disorder cannot coexist with the diagnosis of reactive attachment disorder. Criteria F, the disturbance is evident before age 5. And criteria A, disturbances are evident before a child turns 5 years old. Next slide, please. Diagnostic criteria G. The child has a developmental age of at least 9 months old. The child must have reasoning and cognitive abilities either matching or exceeding that of a 9-month-old. The developmental age of the child must equal, considering all factors involved, at least that of a 9-month-old comprehension. Next slide, please. Thank you. Similar diagnosis and presenting differences. Although both cannot be present in the same individual, autism spectrum disorder can be mistaken for reactive attachment disorder because of aberrant social behaviors, though ASD does not present with abuse and neglect histories. Intellectual developmental disorders is another commonly mistaken diagnosis because of the developmental delays, but is different because they show attachment at a 6 to 9-month-old level. Children can develop depression, but there is no current evidence that depression can or does cause attachment issues. Autism spectrum disorder, although aberrant social behaviors are key to both disorders, there are several differences. The first is a basis of differential history of neglect. The second is presence of interest or rituals. Either condition can cause stereotypic behaviors or exhibit ranges of intellectual functioning, but autism spectrum disorder will exhibit selective impairments in communication. Finally, ASD children will show attachments consistent with developmental functioning. Intellectual developmental disorders, developmental delays are part of both disorders, but IDD will show social and emotional skills comparable to cognitive abilities without demonstrating profound reductions in positive affect and emotion regulation. In addition, children with IDD of 7 to 9 months should demonstrate attachments regardless of their chronological age. Depressive disorders, although children can develop depression, there is no evidence to suggest they have impairments in attachments. Next slide, please. Case example. Johnny was reported to be a difficult child at home, requiring his mother's constant attention, exhibiting extreme anger during typical play and sharing situations, highly impulsive and very much enjoyed using language for the purpose of interrupting the classroom and manipulating the adults. The only information you have were parent complaints of behavior at home. When speaking to his mother, you are surprised to see that as Johnny tried to snuggle up to her, she would roll her eyes and push him away. You later learn this mother has spent years with little to no sleep because he insisted on sleeping on a cot at the bottom of his parents' bed each night and woke up every night pretending to sleepwalk. Johnny uses a very high-pitched and what can only be described as baby talk. After a few months, it became quite clear that the expressive language deficits Johnny exhibited during initial assessment were not an accurate view of his true abilities. In fact, although considered typically developing, he appeared to have higher receptive language skills than he portrayed during testing as well. Academically, when Johnny would slip up a bit and show what he really knew, he demonstrated good rote counting skills, early identification of some letters, and understood concepts of sorting and patterning with ease. However, he had significant difficulties with peer interactions. Next slide, please.
Hi, my name is Ornella Nikai, and I will be presenting on the next few slides about evidence-based intervention. Each child with reactive attachment disorder comes from a unique environment with a unique combination of factors. Therefore, there cannot be one specific treatment and a more dynamic approach is needed. For that reason, a multi-pronged approach is needed for intervention and treatment of reactive attachment disorder. Parent education involvement is crucial for positive treatment outcomes. This includes the caregiver's ability to understand the meaning behind their child's behavior. Parents also need their own security of attachment. This can be done through psychoeducation and therapy. Psychoeducation works best including both parents and child and can improve communication for both as well. Developing a nurturing parent-child relationship is the foundation to overcoming the damage caused by severe neglect and abuse. Having parents show empathy and compassion are key elements to building trust. Psychotherapy is another evidence-based intervention. Psychotherapy includes encouraging the development of healthy attachment relationships, processing traumatic events through play therapy, teaching the child positive coping and anxiety management skills like relaxation and cognitive restructuring. These last two interventions can be done through cognitive behavioral therapy. It was also mentioned that individualized relationship-focused interventions are more effective than standardized behavior modification interventions. Trust-based relational intervention is another evidence-based intervention, and it is an attachment-based theory that focuses on safety, human connection, and regulation. This can be done by empowerment, which focuses on the importance of a safe and structured environment, sensory needs, and nutrition to encourage trust in traumatized children. It can also be done through connection, and that focuses on observational awareness, self-awareness, attachment skills, playful engagement, and attunement. Lastly, through correction, which modifies behavioral needs and focuses on building social competence. TBRI teaches caregivers to give the child a voice, allowing children to be heard and promoting connection. Overall, caring for children with RAD requires an interprofessional wraparound approach. On this slide, I copied and pasted the American Academy of Child and Adolescent Psychiatric Practice Parameter for the assessment and treatment of children and adolescents with reactive attachment disorder of infancy and early childhood. On this slide, you can see the 9 steps that guide clinicians dealing with reactive attachment disorder. After each step, you see either MS, CG, or NE. MS represents minimal standards that are based on substantial empirical evidence, such as well-controlled double-blind trials or overwhelming clinical consensus. CG represents clinical guidelines that are based on empirical evidence, such as open trials, case studies, and strong clinical consensus. And E represents not endorsed, refers to practices that are known to be ineffective. So step 9, it states that therapeutic holding or compression holding, reworking of trauma, and reattachment have no empirical support and have been associated with serious harm, including death. I found this particular step interesting because a lot of the articles I came across while researching mentioned that holding therapy is somewhat effective with little evidence, or the complete opposite on how harmful it can be to the child, and in the step it states how inefficient it can be. And that concludes evidence-based interventions for reactive attachment disorder.
Hi, my name is Alyssa Freeman, and I will begin by sharing a slide that contains connotations that come with the reactive attachment disorders. Thoughts of RAD for both those who have been diagnosed as well as their caretakers are often thought to be bad children, lonely. Both the caregivers and the children are sacrificial, and they have very, very hard struggles. I've also included a mini doc that offers an insight on how parents and caretakers are affected by reactive attachment disorder. Could you please hit play?
For a child to literally want to kill you and say, I'm going to take daddy's gun and shoot you, and then I'm going to take a knife and stab you in the heart and pull it out because then you'll bleed to death. That's pain.
One word that comes to mind to parent a RAD child during the tough times is isolated.
The first one that comes to mind is lonely.
I learned what the word sacrifice really means.
Living with a RAD kid, it's actually surviving.
I think a documentary on RAD is important because it's so misunderstood.
We need to educate. We need to get the word out there that there is help, that they're not the only ones that are going through these daily struggles.
The advantage of a documentary is exactly, you need to live life, not just survive life.
My husband and I adopted our son a year and a half ago so when he was 3.5 years old from the foster care system.
We adopted Jack. We got him when he was 11 months old.
When we first brought our adopted son home, it was pretty chaotic.
You know, if we would hold on to him and he's, I'm going to kill you, I'm going to kill mommy, or I'm going to kill daddy, or I'm going to kill I'd kill the dogs.
Trying to kick and punch and bite and headbutt and anything he could do to cause pain or hurt.
Bitten, scratched, kicked, punched, slapped.
I knew we were in over our heads, and I knew something was really wrong.
Some of it was silly, but yeah, he's 3.
You don't want to believe that a child who's supposed to be young, innocent, loving, can act in the ways that they act.
So when you can picture your 3-year-old son in jail, that's a really scary thought.
And that's not any way to diagnose your son, because that's pretty bleak. It's pretty despairing.
So as you can see, these families often come with lots of struggles. There's not really one reason or set of child. As you saw, they were foster children or adopted children, even biological children in that documentary, that have all faced some sort of reason to have an attachment or detachment. Next slide, please. Implications of reactive attachment disorder can include, these implications can last only several years or be a lifelong diagnosis. Most physicians and mental health practitioners recommend admitting children with reactive attachment disorder to residential facilities. This could offer both positive and negative effects. Positive effects can include structure, specialized treatment plans, medication management through therapists and psychologists. However, negative effects that can occur include limited amount of time with a psychologist. Typically, they have about a 15-minute span of time where the psychologist will see the children only once a month. Children can also pick up behaviors from other children that are in the residential facility. These can be good behaviors or bad behaviors, but typically the bad behaviors outweigh the good. Bad is left untreated. People can begin to or continue to present effects such as not understanding and or lacking normal and necessary social rules, delayed growth both and physically, substance use and abuse, which can exaggerate the symptoms and effects, and poor self-esteem, as well as eating disorders. These effects can also often lead to or be used as a co-occurring disorder. Okay, next please. Critical thinking in terms of reactive attachment disorder, how it becomes a diagnosis, and the effects that reactive attachment disorder have are pretty logical. The children's brain doesn't have an opportunity to form the healthy attachment, a lack of trust, trauma, and so instead reacts negatively towards things that seem helpful and often loving. Co-occurring disorders that are often diagnosed with RAD include cognitive delays, language delays, depression, anxiety, and ADHD. A study completed by all CEU's counseling education found that the relation between PTSD symptoms and the attachment anxieties tend to be stronger with individuals who have a current PTSD diagnosis that relates to early life trauma. It is also found that people who have a RAD diagnosis are at an additional risk for postpartum depression in their adult years. And that is what I've got.